شايفين السكرين؟
واضح يا دكتور.
اوكي، هذيك المرة وصلنا لل differential diagnosis of wrist pain in the athlete, and we will be discussing radial wrist pain, inclusive intersection syndrome. This is a drawing of the hand, and you can notice that there is a cross section of tendons between the extensor indicis, the short and long extensors of the wrist, and the extensor pollicis brevis and abductor pollicis. These tendons at the cross section will have inflammation, and they will get the condition known as the intersection syndrome, where you have inflammation at the intersection exactly. So the intersection syndrome is an acute bursitis at the intersection of the first and second extensor compartment. This injury is most commonly seen in rowers and golfers. You can see it and observe the rowing that is occurring in the Olympic Games in France. You can see the mechanism by which this occurs. It is due to a continuous motion between extension, flexion, and abduction of the wrist, leading to an inflammatory process known as the intersection syndrome. It is between two tendons, which is the extensor longus and the brevis of the second compartment of the wrist, and those tendons that extend and abduct the thumb. So keep this in mind. So it presents with tenderness 5 centimeters proximal to the radial styloid and must be differentiated from decurvent tenosynovitis. If you look at the photograph on the right side, it will show you the site of the two tendons that can intersect with these two extensor tendons to lead to this. On the other hand, you can have an inflammation of the extensor pollicis brevis and abductor pollicis, and these can be inflamed as they pass through the retinaculum to the thumb. This is known as decurvent tenosynovitis, and the tenderness is more distal to the intersection syndrome or synovitis. In these both cases, on motion of the thumb or extension, abduction of the wrist, they will be crepitus, and this is due to the inflammatory process that is taking place. The treatment consists of splinting in a thumb spica brace, activity modification, non-steroidal anti-inflammatory drugs, and sometimes steroid injections, but not into the tendon, around the tendon. Surgery is rarely indicated and is reserved for those in whom non-surgical treatment has been unsuccessful for at least 3 months. Surgery includes bursal debridement and second extensor compartment release. This shows you decurvens tenosynovitis. You see the abductor pollicis longus. You see the extensor pollicis brevis passing through the retinaculum, through the tunnel, and this can get inflamed. More proximally, you get the intersection synovitis, and this is between the two radial extensors of the wrist and the abductor pollicis longus and extensor pollicis brevis intersection. Decurvens tenosynovitis is an overuse syndrome that involves inflammation of the tenosynovium of the first extensor compartment tendons and is seen in racket sport athletes and golfers. These both sportish games lead to repeated flexion, extension, abduction, and adduction of the wrist, irritating these tendons as they pass through tunnels or as they intersect with other tendons, leading to a synovitis. This shows you the site of tenderness of decurvens tenosynovitis as it is passing through the first tunnel to the thumb. These two tendons, the abductor pollicis longus and extensor pollicis brevis tendon, can get inflamed. Symptoms include dorsal-radial wrist pain and swelling with crepitus, as I have repeatedly mentioned, over the tendons, directed with thumb circumduction, the full types of motion combined. And one could also elicit on Finkelstein's test, and by totally deviating the whole wrist in adduction and the thumb into flexion with tenderness on the first tunnel at the retinaculum. They will have pain. This is how we elicit test. You see the whole wrist is being adducted. The thumb is flexed. It is stretching the tendons within the tunnel. And this is a provocative test. By stretching the tendons, one would get pain and irritation. Pain is also elicited with resisted thumb metacarpophalangeal extension by holding the thumb in flexion and asking the patient to extend the first metacarpophalangeal joint. Treatment is similar to the intersection syndrome. Immobilize. Put the wrist to rest, just like we did with the intersection syndrome or synovitis, but with a lower threshold level for surgical intervention. At the time of surgical release of the first dorsal compartment, one should be very careful to inspect the compartment for a separate subsheath that contains the extensor pollicis brevis tendon is needed so that you will release it together. Otherwise, the patient might continue to have pain. In 2011, a novel 4-point steroid injection technique for recalcitrant cases in high resistance athletes was described that yielded better outcomes than the standard 2-point injection technique. And this is shown in this figure. You see, you have 4 points, but never inject within the tendon. Always inject around the tendon. And this gave us good results, together with splintage in neutral position, putting the thumb to rest. In the intersection synovitis, you put the wrist to rest, and also the thumb. While in the tenosynovitis of the first compartment, the thumb is involved. The wrist is also involved. You should put them in a splint and give them a chance to calm down, as a matter of fact, between 10 days and 2 weeks. What else do we have in the wrist that can cause wrist pain? In the radial aspect, we mentioned about the intersection synovitis. We mentioned about decurvent stenosynovitis, but we should not forget about volar wrist ganglions. Volar wrist ganglions can cause pain on the radial aspect of the wrist, usually emanating from the joint via a tear in the radio scapula capitate ligament. Pain is caused by compression of the surrounding structures. If the cyst is appreciable on physical examination, it will trans-illuminate. Usually, no correlation is found with underlying pathology, although other diagnoses, such as a radial artery aneurysm, should be excluded before undertaking surgical excision. Cyst should be excised if painful, although you should let the patient know that there is a 20% risk of recurrence. A volar cyst versus a dorsal cyst should not be aspirated or injected with steroid because of the proximity of the radial artery and potential for injury to destruction. If you know the anatomy well, and if you can feel the pulse, then you are justified to inject away from this area. What about flexor carpi radialis tendinitis? Athletes engage into forceful, repetitive wrist flexion can develop inflammation of the wrist flexors, especially the flexor carpi radialis. Symptoms include volar, radial and ulnar wrist and forearm pain, and are elicited with resisted wrist flexion and radial or ulnar deviation. Localized tenderness is present over the involved tendon. Splinting and steroid injections into the tendon sheath, but not into the tendon. I repeat, not into the tendon, around the tendon, are the first line of treatment. Why do I say this? Because tendons tend to weaken the intercollagen connections and therefore it can rupture with injections within the tendon. Surgical release of the flexor carpi radialis sheath has good results in 80% of the cases. Dorsal wrist pain and dorsal wrist ganglions. Approximately 70% of dorsal wrist ganglions emanate from the scapholunate wrist ligament. Pain associated with a dorsal wrist ganglion should increase your concern for a scapholunate ligament injury. Ganglions not associated with pain may be observed. They can be aspirated if painful, but have recurrence rates of 20 to 50%. You have to be careful if you want to inject within the ganglion corticosteroids such as methylprednisolone. You could stain the skin in the area white, and the patient might not like it. So steroid injections of the cyst really have no benefit. Surgical excision is usually successful at relieving symptoms, although up to 20% of the ganglions recur. Keep this in mind. Arthroscopic excision allows direct visualization of the scapholunate ligament as well as the remainder of the wrist joint and debridement of the capsular stalk at the base of the cyst. You should ligate this. We believe it could be a herniation, and synovial fluid passes through this herniation into the cyst. Arthroscopic excision has a slightly lower recurrence rate than open excision. Scapholunate ligament injuries. If you should always look at the scaphoid and look at the lunate during falls on the wrist, besides investigating the scaphoid for a fracture. If you see a gap, as is shown in this red arrows, then you should know that you have a scapholunate injury. And these are treated usually by pinning and repairing. Scapholunate ligament injuries also cause dorsal wrist pain. So now you have a broad differential diagnosis of wrist pain. As with scaphoid fractures, scapholunate ligament injuries are often missed on initial presentation. So you should be alert to look for it. And these are challenging for the orthopedic hand surgeon to treat if they present in a delayed fashion. Examination will reveal tenderness at the scapholunate interval, as well as a positive scaphoid shift test. You should know how to demonstrate this. Wrist radiographs should be obtained and include a clenched fist view. A clenched fist view usually promotes stress on the scapholunate ligament, and it widens the space between the lunate and the scaphoid. You should always look for widening between the scaphoid and lunate. Look at the figure or the slide below. What about this test? The Watson test, the scaphoid shift test. is a painful dorsal scaphoid displacement as the wrist is moved from ulna to radial deviation with compression of the tuberosity. You can palpate the scaphoid, and as you move it from abduction to adduction or adduction to abduction, you can feel a sort of a click, and this would tell you whether you have instability between the scaphoid and the lunate. And look at the figure above. Look where the thumb is being placed on so that you can feel this. More than 3 millimeters of widening, which is called the Terry-Thomas sign, suggests a ligament tear on the lateral view. An increased scapholunate angle may be appreciated, and this may be greater than 90 degrees. Look at this slide. You see the gap between the scaphoid and the lunate. And look at Terry Thomas, between both teeth, the gap. It looks like a scapholunate separation of the teeth. Dynamic widening of the interval is appreciated when the widening only occurs with the clenched fist view. You ask the patient to promote a wrist flexion or a clenched fist and take an AP view. You see by clenching the fist, it creates stress in between the scaphoid and lunate and promotes a widening. If you take an AP X-ray with the wrist and fingers extended, it might confuse you and say that there is no separation. Look at this X-ray. On the left-hand side, the hand is extended. There is no clenching. The fingers are extended. Look with the scapholunate gap. There is no gap. But on the right-hand side, you see that on clenching the wrist, look at the gap. It becomes more than 3 millimeters. There is a scapholunate dissociation. This is a technique done in the operating room, which is known as the carpal stretch test, with the patient under anesthesia. You take an X-ray view, and it will show that there is a gap. In addition, you should look for the capitate. You should see where its position is. Make sure that there is no rupture of the lunocapitate ligament. Look at the capitate of how it's migrating proximally. It tells you that there is a ligamentous tear. There is a ligamentous tear between the capitate and lunate and scaphoid. You have to keep your eyes open. Static widening can be seen on all views and is usually associated with a chronic injury and will result in arthritis over time. When you're watching the Olympics on TV occurring in France, I'm sure many of these sportish groups have had a scapholunate injury or a capitate scapholunate injury. So these ligaments can be under strain as they are stretched, especially those who are climbing on the walls and they jump from one level to the other, and they bear the whole load of the body on the fingers and the wrist. MRI can be helpful in the diagnosis, although it only has a 70 to 81% accuracy. Arthroscopy is the gold standard in diagnosis. Acute tears should undergo surgical treatment acutely when possible, with open reduction of the scaphoid and lunate, with dorsal wrist, capsulodesis, or ligament repair and percutaneous pin fixation. This is an arthroscopic view of the mid-carpal space. The probe in the scapholunate interval demonstrates a scapholunate ligament tearing. You can see the gap between the scaphoid and the lunate. So the arthroscopic view gives us an accurate diagnosis. Numerous reconstruction techniques have been described for static chronic injuries more than 6 weeks post-injury. More recent data have shown better radiographic outcomes with ligament reconstruction over wrist capsulodesis and for chronic injuries. Now we shift from the radial aspect of the wrist. We spoke about tendinitis of the extensor carpi radialis. We spoke about the tendons to the thumb, the extensor tendons, the abductor tendons. We spoke about ganglions. We spoke about scapholunate tears. All these put together with intersection synovitis is the differential diagnosis for radial wrist pain. And in an exam, we could ask you, give us the differential diagnosis of radial wrist pain. Don't forget about the ganglions. Don't forget the extension of the ganglions. Is there any relation to the scapholunate ligament? Keep these in mind. Now we're shifting to the ulnar aspect. Extensor carpi ulnaris tendinitis. Injuries to the extensor carpi ulnaris. The triangular fibrocartilage, don't forget, it's a very important structure in the wrist. And usually in distal radial fractures, I've noted that many tend to forget about the distal radio-ulnar joint, which if not well reduced would let the patient have a chronic pain in the wrist. They are common diagnoses in the athletes complaining of ulnar-sided wrist pain. Sports requiring repeated pronations and supination, radial and ulnar deviation, and axial loading of the forearm and wrist predispose these athletes to ulnar-sided wrist pathology. Extensor carpi ulnaris, the distal radio-ulnar joint, and the triangular fibrocartilage complex injuries are reported in athletes participating in golf, football, tennis, baseball, rugby, hockey, and basketball players. These injuries are a common source of ulnar-sided wrist pain in an athlete population and may result in missed time from sport. Early diagnosis and treatment is critical in this population in order to minimize time away from sport. What about the extensor carpi ulnaris? Briefly about the anatomy. The extensor carpi ulnaris originates from the lateral epicondyle and inserts on the base of the fifth metacarpal. At the level of the wrist, the extensor carpi ulnaris tendon passes through the sixth dorsal extensor compartment within the extensor carpi ulnaris groove on the dorsal aspect of the ulna. So it arises from the lateral epicondyle and moves, or its root, it goes ulnaward on the extensor aspect of the wrist to enter the sixth tunnel and inserts on the base of the fifth metacarpal bone on the dorsal aspect or on the upper aspect of the bone. It has its groove and tunnel through which it passes. Extensor carpi ulnaris tendon is held within its groove by the extensor retinaculum and its own separate subsheath in the distal 1.5 to 2 centimeters of the ulna. The proximal half of this subsheath has a greater contribution than the distal half in providing dynamic stabilization of the extensor carpi ulnaris in its groove. The ulnar wall of the sixth compartment, which houses the extensor carpi ulnaris tendon, is composed of transverse fibers that extend proximally, becoming confluent with the epimysium of the extensor carpi ulnaris muscle. These fibers are referred to as linea jugata. The function of the extensor carpi ulnaris depends on the position of the wrist. In supination, the tendon lies dorsal to the center of rotation of the wrist, thus contributing more to extension in this position. Conversely, in pronation, the tendon lies more palmar and ulnar, diminishing its contribution to extension. The rotation of the wrist affects the angle at which the extensor carpi ulnaris tendon exits the subsheath, coursing towards its insertion point. In supination, the tendon exits at approximately 30 degrees compared to the pronation position, in which the tendon exits in a more longitudinal direction. It is believed that tension on the subsheath is greatest during activities involving supination and holding the wrist in a flexed and ulnarly deviated position. Distal ulnar morphology may also play a role in the development of extensor carpi ulnaris pathology. What about the variance? Negative ulnar variance was associated with the presence of extensor carpi ulnaris pathology and instability. The depth of the ulnar groove was also evaluated, and shallow grooves tended towards significant extensor carpi ulnaris pathology. So you should not forget that the extensor carpi ulnaris is an important tendon, together with its sheath, with its being pulled out of its tunnel or not. And it can be damaged, and these patients could have pain on the ulnar aspect of the wrist. What about a large ulnar styloid? May also contribute to the development of tendinopathy via direct mechanical irritation of this tendon. Extensor carpi ulnaris is classified broadly into 3 groups. It can undergo instability, tendinopathy, or tendon rupture. Clinically, it is useful to group extensor carpi ulnaris related injuries in this way, as it helps to guide treatment on surgical exploration and repair or reconstruction of the extensor carpi ulnaris subsheath. There are 3 types of extensor carpi ulnaris sheath disruptions. You can have an ulnar disruption, a radial disruption, and you can have a disruption with the periosteal avulsion of the extensor carpi ulnaris subsheath. What about the diagnosis? I spoke so much about the extensor carpi ulnaris pathology, subluxation, rupture of the sheath, tendon ruptures. Now we want to examine the patient. The clinical examination is very helpful in differentiating the etiology of ulnar-sided wrist pain. In the case of an unstable extensor carpi ulnaris tendon, an acute event is often noted by the patient. Patients with a stable extensor carpi ulnaris tendon who have tendinopathy will more likely present with vague dorsal ulnar wrist pain with a history of more insidious onset. On physical examination, patients with instability may present with a spectrum of symptoms. In some cases, dislocation of the tendon is reproducible and may be painful or painless, depending on the chronicity of the situation. Passive motion may not place enough tension on the tendon to reproduce symptoms, and active examination should be undertaken. Pain with resisted extension and ulnar deviation may be indicative of tendinopathy or tenosynovitis as well. Pressure within the 6th extensor compartment is highest when the wrist and forearm are supinated, and patients with tendinopathy will experience pain in this position. Weakness in the absence of pain may indicate a rupture of the extensor carpi ulnaris tendon. What about the extensor carpi ulnaris synergy test? It is a described maneuver proposed to help differentiate extensor carpi ulnaris pathology from other intra-articular diagnoses. The test is performed with the patient's arm resting on a table and elbow flexed to 90 degrees with the wrist in supination. the patient is asked to radially abduct the thumb against resistance and reproduction of pain in the extensor carpi ulnaris is positive. This is the extensor carpi ulnaris synergy test. You see the arm is resting on the table. The elbow is flexed to 90 degrees. The forearm is in full supination. The wrist is neutral and the fingers are fully extended. The examiner grasps the patient's thumb and middle finger and palpates the extensor carpi ulnaris tendon with the other hand. The patient then abducts the thumb against resistance. The presence of both extensor carpi ulnaris and flexor carpi ulnaris muscle contraction is confirmed. Recreation of pain along the dorsal ulnar aspect of the wrist is considered to be a positive test for extensor carpi ulnaris tendinitis. Just look at this photograph. You can see the prominence of the extensor carpi ulnaris. You can see of how the left hand is holding the thumb. The thumb is in abduction, and the examiner grabs the middle finger and the thumb and tries to bring them together. As he tries to bring them together, you see the patient will have a prominence of the extensor carpi ulnaris. This could indicate a rupture. It can indicate a subluxation or dislocation of the tendon. Imaging, magnetic resonance imaging. Magnetic resonance imaging may be useful in the diagnosis of extensor carpi ulnaris pathology, tenosynovitis, and tendinopathy will manifest as areas of increased signal intensity on T2, although areas of altered signal intensity may also be found in normal tendons as well. One recent study reports a sensitivity of 57% and specificity of 88%. The integrity of other critical structures, including the extensor retinaculum and extensor carpi ulnaris subsheath, may be evaluated using MRI as well, but may not be consistently seen in all exams. Knowing the position of the extensor carpi ulnaris tendon is highly dependent on the position of the wrist. Examinations should be taken in both pronation and supination. The MRI may be valuable in identifying extensor carpi ulnaris pathology. The entire wrist is concomitantly evaluated with these studies, allowing for the diagnosis of other possible causes of symptoms as well. What about the use of ultrasound? Ultrasound examination may be performed in pronation and supination, and it allows for contralateral comparison and may assess inflammatory changes. Dynamic evaluation in different positions may be useful in the diagnosis and easily performed with ultrasound. Ultrasound examination studies in healthy volunteers demonstrate up to 50% volar displacement of the extensor carpi ulnaris tendon in maximum supination, ulnar deviation, and flexion of the wrist, and may be a normal finding. Up to 75% of asymptomatic wrists may demonstrate tendinosis or tearing on ultrasound. It is important to correlate imaging with clinical findings. What about the treatment? Tendinosis of the extensor carpi ulnaris is often treated non-surgically. Rest, activity modification, and a period of immobilization will often resolve symptoms. This is followed by progressive rehabilitation protocols in order for athletes to return to their normal activities. In more chronic cases or cases that do not respond to conservative management, surgical intervention may be called for. Division of the tendon in the affected area and debridement of necrotic tissue diminishes tendon size and may help alleviate symptoms. Surgical exploration also allows for evaluation of any extraneous septa between the extensor carpi ulnaris and the extensor digiti minimi, which is in the neighboring tunnel. Release of the division between the fifth and the sixth extensor compartments should also be considered to help decompress the sixth compartment, which can contribute to improvement of symptoms. In cases of extensor carpi ulnaris instability, conservative management should be attempted as well. This involves a period of immobilization in pronated, extended, and radially deviated position for 6 to 8 weeks in order to maintain the extensor carpi ulnaris tendon deep within its groove. This may require a long arm cast if stability cannot be achieved in a short arm cast. Periodic stress examination and evaluation with ultrasound and/or MRI may be useful to ensure that there is healing of the extensor carpi ulnaris sheath. Continued instability indicates the need for continued immobilization or for surgical management. Surgery is proposed by some investigators as the first-line treatment for acute traumatic extensor carpi ulnaris instability, especially in athletes, and is further indicated for cases that do not respond to conservative management. Management depends on the type of subsheath injury that is encountered. In cases of periosteal avulsion, the avulsed periosteum should be reapproximated with the transosseous fixation or suture anchors. When the sheath itself is torn or elevated from its insertion, direct repair may be attempted, or reconstruction of the sheath should be completed using a strip of extensor retinaculum or periosteum. Complete rupture of the extensor carpi ulnaris tendon is uncommon in athletes. However, if this injury occurs in an active patient, reconstruction of the tendon with the use of a palmaris longus graft should be considered. Postoperative care of these patients depends on the procedure performed. For procedures involving simple synovectomy with or without debridement, wrist immobilization for 2 weeks in a short arm splint should be done. If reconstruction of the extensor carpi ulnaris sheath, as described previously, is performed, immobilization in a long arm cast for 4 to 6 weeks with the forearm in neutral rotation and elbow at 90 degrees. Restricting return to sport or vigorous activity for another 2 months after immobilization is discontinued and therapy has begun. What about the take-home message? And this is what I'm going to speak in general. Extensor carpi ulnaris tendinitis, you should remember that it is seen in racket sport athletes and baseball players. The sixth extensor compartment is a unique fibroosseous compartment that holds the extensor carpi ulnaris tendon tight against the ulnar groove. As the forearm is supinated, the sheath prevents the ulnar translation of the tendon. Tenderness is elicited directly over the extensor carpi ulnaris tendon on examination. Radiographs are obtained to rule out fractures of the ulnar styloid and other bony pathologies. MRI sometimes shows splits in the tendon or increased signal intensity in the tendon on T2 weighted images. Non-surgical management is preferred using non-steroidal anti-inflammatory drugs, splints, and restricted activity. Steroid injections can help relieve pain. If non-surgical management fails, the extensor carpi ulnaris tendon can be debrided. The retinaculum of the sixth extensor compartment must be repaired carefully to prevent instability. Extensor carpi ulnaris tendon subluxation is most commonly seen in tennis players, usually resulting from hypersupination and for ulnar deviation injuries. This shows you of how the extensor carpi ulnaris tendon subluxation can occur. You can have a rupture, and as a result, you can have a false rupture or a subluxation. This is in a transaxial view. On examination, the extensor carpi ulnaris tendon painfully snaps out of the groove with supination and ulnar deviation. The distal tendon is palpable. Acute treatment is with a long arm cast, impronation, and slight radial deviation. Chronic instability requires compartment reconstruction performed with direct repair supplemented using a radial-based sling of retinaculum or a free graft from the retinaculum. The ulnar groove can also be deepened to further stabilize the tendon. This is strongly associated with triangular fibrocartilage complex tears. Wrist arthroscopy should be considered at the time of surgery if a triangular fibrocartilage complex tear is suspected. Now we come to the ulnar tunnel. 1 second, I want to ask for a glass of water. Now, ulnar tunnel syndrome. Over here is the ulnar nerve as it's passing through a tunnel. This tunnel is known as Guillen's Canal. It is bounded by the pisiform and the hamate and the piezohamate ligament from the front. It consists of a superficial, sensory, and deep motor branches. The ulnar tunnel syndrome consists of entrapment of the ulnar nerve in the Guillen's Canal at the wrist. And another name for Guillen's Canal syndrome, or what you want to call it, is called the handlebar palsy. What do we mean by it in cyclists? لما الواحد بيكون riding on bicycleted course and he is leaning on the steering wheel or steering, whatever you want to call it, all the pressure comes on Guillen's Canal. And this can lead to Guillen's Canal syndrome, and it may be associated with carpal tunnel syndrome. Look at the handle of the bike, how the patient has his hand holding on the handle, and there is pressure on Guillen's tunnel. Look at it. Never forget it. I put these photos, I searched for it in many books to get it for you so that you will never forget it. Depending on the location of the compression, patients can have motor or sensory symptoms or both. Paresthesias are noted in the ring and little fingers, half of the ring, longitudinal wise, and the intrinsic muscles are often weak. This condition can also be caused by a mass, a lesion, such as an ulnar artery thrombosis or aneurysm, or falls landing on the hook of the hamate, resulting in a fracture, can create pressure on this canal. A ganglion occurring in the area or a lipoma can cause it. Inflammatory conditions, inflammatory arthritis, bony anomalies, and any condition that can lead to continuous pressure on Guillen's Canal would lead to it. This shows you an aneurysm occurring and leading to it. On the right-hand side, we have a fracture of the hook of the hamate, and this will cause pressure on the ulnar nerve as it's passing through Guillen's Canal. So look, in this photo, we have an aneurysm on the left side and a fracture on the right side. You can have a ganglion, you can have a tumor, you can have a lipoma. All these will lead to pressure and lead to this condition. This is further showing you the various conditions that can lead to the ulnar tunnel syndrome. Nerve conduction velocity studies and electromyography can support the diagnosis, and the MRI can be helpful if a mass lesion is suspected. Non-surgical therapy includes wrist splints and avoidance of aggravating activities. Ulnar artery thrombosis, also known as the hypothena hammer syndrome, can occur in baseball catches because of repetitive impact to the ulnar artery while catching the ball. This shows you a case where the patient had an ulnar artery thrombosis. This was proven by MRI. This is an aneurysm. Surgery involves nerve decompression and removal of any masses or lesions. And if the patient has concomitant carpal tunnel syndrome, release of the carpal tunnel is sufficient for release of the ulnar tunnel as well. You don't need to do a release of the ulnar tunnel when you're doing a release of the carpal tunnel as the patient has a carpal tunnel syndrome. Symptoms include pain, cramping, and sensory disturbance. The Allen test should be performed if diagnosis is suspected with delayed reperfusion appreciated while occluding the radial artery. Ulnar artery reconstruction with interposition of vein grafting is required. Now we come to a topic which is of interest to all, the triangular fibrocartilage. And at the same time, we will be discussing the distal radio-ulnar joint anatomy. Now, look at this slide. Note the structures that I'm demonstrating. The distal end of the radius, distal end of the ulnar, the ligaments between the distal radius and ulnar, the triangular fibrocartilage, which extends from the base of the ulnar styloid process to the foveal margin of the radius. So the triangular fibrocartilage is composed of a triangular fibrocartilage, ulnar collateral ligament, the superficial and deep dorsal volar radial ligaments or radial-ulnar ligaments, and the sheath of the extensor carpi ulnaris. The superficial radio-ulnar ligaments become continuous with the extensor carpi ulnaris subsheath, and the deep layer, often referred to as the ligamentum subcruitorum, inserts into the fovea and base of the ulnar styloid process. I will be showing you this. You see on the extreme right, you have the ulnar styloid process. On the superficial portion, you can see the triangular fibrocartilage from both sides inserting on the fovea of the distal end of the radius. The deep portion is known as the ligamentum subcruitorum, exactly its deep arising from the base of the styloid process, accompanying the superficial portion and inserting on the fovea, on the margin of the distal end of the radius on the ulnar aspect. Anatomically located between the ulna and the carpus, the triangular fibrocartilage complex serves as a load-bearing structure, just like the meniscus of the knee, and it absorbs 18 to 20% of the load across the wrist. Now, in ulna positive morphology, meaning that the ulna being longer at its distal end with respect to the radius, the force is transmitted across the joint and it is increased and conversely decreased in ulnar negative morphology where the ulna is shorter. So the load increases with ulnar positive morphology and it decreases with ulnar negative morphology. The force across the ulnar carpal articulation is increased with gripping activities and pronation of the wrist. The thickness of the triangular fibrocartilage increases in ulnar negative patients and decreases in ulnar positive patients. Why? Because there's not enough space if it's ulnar positive. If it's ulnar negative, where the ulna is short, it is filled in by this cartilage. The triangular fibrocartilage is supplied by branches of the ulnar artery that penetrate the triangular fibrocartilage complex in a radial fashion from volar, dorsal, and ulnar sides, reaching the peripheral 10 to 40% of the triangular fibrocartilage. So, like in the meniscus of the knee, the periphery of the cartilage is well vascularized. As you move centrally, it becomes less vascularized to avascular. The central and radial portions are relatively avascular, limiting their healing potential, just like in the knee, relative to the more peripheral portions. Recent cadaveric studies demonstrate innervation of the triangular fibrocartilage complex by the dorsal cutaneous branch of the ulnar nerve, 100%, medial antebrachial cutaneous nerve, 91%, and volar branch of the ulnar nerve, 73%. So it has a good nerve supply at the periphery, especially. With respect to the distal radio-ulnar joint, it is generally agreed that the dorsal superficial radio-ulnar ligaments and volar deep radio-ulnar ligaments tighten and stabilize the distal radio-ulnar joint in pronation. Conversely, in supination, the deep dorsal and superficial volar ligaments tighten. Again, this is a diagram which shows you of how the extensor carpi ulnaris and its subsheaths in relation to the ligaments about the triangular fibrocartilage. We have the ulnar collateral ligament, well demonstrated. You have the deep dorsal and volar radio-ulnar ligaments. You have the dorso-radio-ulnar capsule. You have the muscles, the quadratus, pronator quadratus muscle, and you have the interosseous membrane. All this you should be well acquainted with anatomic-wise. While the bony articulation between the radius and ulna and the pronator quadratus stabilize the distal radio-ulnar joint as well. classification, actually it was Palmer who classified these at the very beginning. Triangular fibrocartilage complex, injuries in traumatic or degenerative lesions, and subsequently subcategorized them based on the location of the lesion. So the major division is traumatic or degenerative. The Palmer classification does not classify all variations of the peripheral triangular fibrocartilage complex tears specific to their impact on the distal radio-ulnar joint stability. Atzi et al. Proposed a treatment-oriented approach to describing triangular fibrocartilage tears. Their classification divides the triangular fibrocartilage into three primary structures. The proximal triangular ligament, the ligamentum subpruitum. The distal hammock structures, the superficial portions, the ulnar collateral ligament. Injuries are classified into 5 classes with corresponding suggested treatment as shown in the following table. This is the classification. First of all, you have an isolated ulnar styloid fracture without a triangular fibrocartilage injury. The treatment is splinting. You can have isolated peripheral tears of the distal hammock without distal radio-ulnar joint instability. Here you need only a suture. You can have a complete tear of the proximal deep fibers from the fovea, resulting in positive hook test, indicating loosening of the triangular fibrocartilage. Then you can have complete tears. Then you have non-repairable triangular fibrocartilage tears, and then triangular fibrocartilage tears in the setting of distal radio-ulnar joint arthritis. In this very last condition, the only thing that can be done is the arthroplasty. What are the diagnosis and clinical examination? This is what concerns us at your stage. Patients presenting with pathology of the triangular fibrocartilage complex and distal radio-ulnar joint may recall a specific event indicating a traumatic injury. In more chronic degenerative injuries, there typically is no inciting event. Pain is typically localized to the ulnar wrist and aggravated by activities that load the wrist or pronation supination on pronation supination activities. There are several physical exam techniques that have been described to assess the triangular fibrocartilage complex and distal radio-ulnar joint. Exam maneuvers include the piano test or the piano key test, just like a piano, the ulno-carpal stress test, the pisiform boost test, the press test, the distal radio-ulnar joint ballottement, and dynamic examination of the ulnar head with active pronation and supination. This is the piano key test. You support the radio while the forearm is in pronation. Then you can hold the ulna, press it up and down. And if you press it down, it would return just like a piano measure, just as if you're pressing on a piano to produce a tone, then it returns back to its space. Okay, so this is the piano key sign. The ulno-carpal stress test is well demonstrated over here. You strain the whole area, and then you find that there is instability. And you can apply pressure over the area of the styloid process, and this is the ulnar press test. Additional tests such as A positive ulnar fovea sign may also indicate ulnotriquetral ligament injury. These tests may elicit pain or detectable instability compared to the contralateral side, which may help delineate the diagnosis. And this shows you the fovea sign. You hold the whole distal end of the ulna and you can mold it, you can move it. It's unstable. The use of ultrasound to better determine the degree of displacement of the distal radio-ulnar joint has been proposed. This test is performed by manually stressing the distal radio-ulnar joint and measuring the displacement of the ulna relative to the radius. Comparing displacement to the contralateral unaffected wrist, the authors report 88% sensitivity and 81% specificity. What about imaging radiographs? Plain radiographs are typically part of the initial workup for patients and is helpful in identifying any underlying fractures, arthritic change, and gross malalignment. Particularly determination of the ulnar variance and or the presence of an ulnar styloid fracture are of interest in assessing the triangular fibrocartilage and the distal radio-ulnar joint. Positive ulnar variance may predispose patients to ulnar impaction and degenerative tears of the triangular fibrocartilage due to repeated compression, due to repeated loading, due to the ulnar positive problem. You have to keep this in mind. Often measured with the wrist in neutral, a pronated position with maximal grip effort results in further proximal migration of the radius, increasing the ulnar variance. So keep this in mind. Gapping between the distal radius and the ulna in this position compared to the contralateral side can also be assessed and is suggestive of the distal radio-ulnar joint instability. In the case of distal radius fractures with associated ulnar styloid fractures, or in isolated ulnar styloid fractures, associated injury of the triangular fibrocartilage complex should be seriously considered. Fractures involving the base, I repeat, I put this in red because fractures involving the base of the ulnar styloid and displacement of 2 to 4 millimeters are more often associated with triangular fibrocartilage complex and distal radio-ulnar joint instability, and this should be taken care of. Many people who have fractures of the distal radius with fracture of the base of the ulnar styloid process, you should reduce the ulnar styloid to retain stability of the distal radio-ulnar joint. Take this as a note and never forget it. Magnetic resonance imaging is a commonly used imaging tool in the assessment of potential triangular fibrocartilage complex injuries. Conventional MRI has shown variable effectiveness with sensitivity ranging from 67 to 100% and specificity from 71 to 100%. Of note, the prevalence of an abnormal finding on MRI was significantly higher in the greater than 50-year-old group. Subluxation of the distal radio-ulnar joint as measured on axial MRI was proposed as another measurement to identify triangular fibrocartilage foveal disruption. Magnetic resonance arthrography, this is the most accurate, it's become very popular, has also been employed in the diagnosis of triangular fibrocartilage complex pathology and has been shown to be superior to MRI alone. Lee et al. Compared 3 Tesla MRI to MR arthrography in 37 patients with central triangular fibrocartilage complex tears and 50 peripheral tears. All tears were confirmed by arthroscopy. The authors showed an increased accuracy in magnetic resonance arthrography group compared to MRI alone in the diagnosis of central triangular fibrocartilage tears. Similarly, in a more recent study, Bahwa et al. Demonstrated 100% accuracy of magnetic resonance arthrography compared to 75% in MRI alone. So you have to keep this in mind. Further supplementation of MRA has also been proposed, including the use of traction to help increase visualization of the joint space. Lee et al. Supplemented the use of finger straps to apply traction during MRA or magnetic resonance arthrography and showed a significant improvement in visualization of the joint space. So if you're asked the question, what would you prefer to use? Always prefer MRA or magnetic resonance arthrography, as well as increasing accuracy of diagnosis compared to pre-traction assessment. CT arthrography is an alternative imaging modality in the diagnosis of TFCC injury in a cadaveric study of 10 specimens. Lee et al. Demonstrated 100% sensitivity, specificity, and accuracy of CTA in the diagnosis of triangular fibrocartilage complex tears. Morimoto subsequently described CT arthrography protocol that visualized TFCC in multiple planes, and it gives us a certain amount of accuracy. So the treatment and surgical indications. In the absence of distal radio-ulnar joint instability, pay attention to what I'm saying. In the absence of distal radio-ulnar joint instability, conservative management of triangular fibrocartilage complex tears is the first-line treatment. Bracing, taping, activity modification, and corticosteroid injections in chronic tears should be trialed first. A recent study found that a period of 4 weeks of immobilization resulted in symptomatic relief in 57% of patients with triangular fibrocartilage complex pathology in one cohort. If the patient fails conservative management, then surgical intervention should be considered. The timing of intervention is largely dependent on the athlete's ability to perform at their desired level. Other considerations, such as remaining time in the season, time left in their playing career, contract implications, social history, and playing time should all be part of the decision-making process in the high-level athlete. What about the operative treatment? What should we do? Central tears. Central tears of the triangular fibrocartilage that lack, as you recalled when we first started, the central portion of the triangular fibrocartilage is avascular. It's avascular. And these lack vascularity, do not have the same healing potential as more peripheral tears, and thus are treated with debridement to a stable edge. Additionally, the use of thermocoagulation has been proposed as an adjuvant treatment in these conditions. Heat applied to the collagenous articular disc may lead to shrinkage and stabilization of the tissue, changing the mechanical properties of the triangular fibrocartilage complex. Additionally, the use of electrothermal treatments has been shown to eliminate neuronal markers in treated tissues, suggesting denervation of the treated areas, which may contribute to pain relief as well. In the setting of ulna-positive variants, debridement alone may not fully address potential symptoms stemming from the ulnar impaction or abutment. Concomitant ulnar shortening osteotomy or the wafer procedure may be considered. Shortening the ulna decreases the load across the ulnar carpal joint and can help relieve symptoms stemming from any impaction of that joint. In patients whom require less than 2 to 3 millimeters of shortening, a wafer procedure, either open or arthroscopic, can be considered. Potential advantages of the wafer procedure compared to ulnar shortening osteotomy include no need for bony healing. It avoids the use of hardware and has a more limited exposure and potentially a faster recovery time. While the wafer procedure has shown comparable outcomes to ulnar shortening osteotomy, there has been no evidence of superiority of one procedure over the other. However, in the setting of significant ulnar positive variants or patients with concurrent lunotriquetral instability, more significant shortening is required, and ulnar shortening osteotomy is the نعم
انا خليتها مع ذي خلاص
ما بسمع
هذا على اساس زيرو
نعم and ulnar ما عم بفهم مش واضح.
عفوا دكتور استمر بس المايك افتتح.
مفهوم؟ عم تسمعوا كل شيء؟
واضح جدا دكتور.
Okay. And ulnar shortening osteotomy is the treatment of choice. Ulnar shortening osteotomy specific hardware is available, which comprises of a low profile plate with a built-in guide, allowing for more precise cuts and reliable compression. Partial resection of the distal portion pole of the ulna or wafer procedure was designed to treat ulnar impaction syndrome and symptomatic tears of the triangular fibrocartilage complex. Now, this is how we do these procedures. It can be done open or arthroscopically. If you look over here on the left-hand side, you have a overgrown ulna. There is signs and symptoms of ulnar impaction by sclerosis over the base of the lunate. In this technique, we prefer to do a shortening of the ulna. And by doing so, the patient will have subsidence of his symptoms. What about the peripheral tears? Peripherally located tears have more healing potential. As I said, the vascularity is much better than the central tears, and thus are indicated for repair when conservative management has failed. Furthermore, disruption of the foveal attachment may result in distal radio-ulnar joint instability, further necessitating surgical stabilization. Repair options include open and arthroscopic techniques. Nakamura suggests that arthroscopically treated triangular fibrocartilage complex injuries may have better outcomes in acute injuries, meaning less than 7 months, compared to chronic injuries, more than 7 months. In their series, there was no difference in measured outcomes based on chronicity of the injury in the group treated with open treatment. The arthroscopic group was found to have greater improvements when compared to the open group. The use of a smaller capsulotomy with less local trauma and greater accuracy of suture anchor placement may contribute to better outcomes in the arthroscopically treated groups. The use of a palmaris graft or extensor carpi ulnaris half split to reconstruct the foveal attachment of the triangular fibrocartilage has the theoretical advantage of osseous integration of tendon through bone tunnels. Nakamura et al. Reported a series of patients undergoing extensor carpi ulnaris half slip reconstruction with 21 of 25 patients with excellent outcomes and 22 of 25 with a stable distal radio-ulnar joint. So, what about the radial-sided tears as a final aspect on triangular fibrocartilage injuries? And this is due to a limited vascular supply to the radial portion of the triangular fibrocartilage. These lesions are often treated with debridement, but if there is instability of the distal radio-ulnar joint, however, then the repair is recommended. In conclusion, ulnar-sided wrist pain in athletes may often be a daunting diagnostic dilemma. However, with a thorough history and physical examination and the use of supplemental imaging modalities, the diagnosis may be quite straightforward. Athletes should be treated as all patients, but additional information, such as the patient's preferred sport, where they are in the season, and their career, and what their ultimate goals are, professional versus recreational, should be included when contemplating treatment. Extensor carpi ulnaris injuries and triangular fibrocartilage complex and distal radio-ulnar joint injuries are quite common in patients whose sports require torsion and rotation of the wrist and forearm. These patients are ubiquitous in any hand specialist practice. Guidelines as outlined above will help demystify what is often referred to the black box of the wrist, ulnar sided wrist pain. The take-home message: triangular fibrocartilage injuries is the primary stabilizer of the distal radial ulnar joint. If it's injured, this does not exist, and is composed of a central disc, a peripheral disc, carpal ligaments that are more volarly placed. Triangular fibrocartilage complex tears can be traumatic or degenerative. Keep these in mind. This region allows the wrist to twist, straighten, rotate, bend, and move left to right. It is composed of the ulnar collateral ligament, which is one. Look at the diagram. The ulnar triquetral ligament, two. The ulnar lunate ligament. You can see it at the point of the arrow. The palmar radio-ulnar ligament, which is 4. The triangular fibrocartilage, 5. The dorsal radio-ulnar ligament, 6. The extensor carpi ulnaris tendon sheath. All this forms the triangular fibrocartilage complex, where you can have tears in the central position. They don't heal well. In the periphery, they have better circulation and they heal well. And it's indicated that you repair these, while the central, you debride them. So keep this in mind. Injury to the triangular fibrocartilage complex causes pain and perceived instability that can prevent athletic participation. So please keep this in mind. Peripheral injury has the best likelihood of healing because this portion has the best blood supply. Tenderness over the anterior ulna, which we spoke about, a positive fovea sign, is evident on examination. Radiographs are obtained to assess the ulnar variants, whether positive or negative, and rule out ulnar styloid fractures. MRI is of help, although studies have shown magnetic resonance arthrography to be more helpful. Please keep this in mind. Wrist arthroscopy confirms the diagnosis. This slide shows a tear. It's an arthroscopic view of the triangular fibrocartilage seen from the radial side of the wrist. The triangular fibrocartilage is detached from the radius. You can see it. The classification is based on the location of the tear and the chronicity. Type 1 tears are traumatic. Type 2 tears are degenerative. Treatment consists of rest, splinting, non-steroidal anti-inflammatory drugs, and steroid injections versus arthroscopic surgical debridement or repair. Ulnar-sided peripheral tears should be repaired. Central and radial tears can truly be debrided. Ulnar tears that are repaired within 3 months regain 80% of motion and strength. The surgeons should be aware that a knot tied in the fiber of an extensor carpi ulnaris sheath can cause extensor carpi ulnaris tendinitis. If a central tear is debrided, a 2 mm peripheral rim of the triangular fibrocartilage should be preserved after debridement to maintain a stable joint. Partial thickness tears of the ulnar fovea do well with repair, and patients who play racket sports are often able to return to sport. However, athletes who bear weight throughout the wrist have less favorable return sport outcomes. If ulnar variants of more than 2 millimeters exist, resulting in symptomatic ulnar carpal abutment, ulnar shortening, or do an arthroscopic wafer shortening should be performed. Excellent results have been achieved by ulnar shortening because this stabilizes the distal radial ulnar joint, reduces the effect of ulnar carpal abutment, and decreases the force on the triangular fibrocartilage. So in summary, hand and wrist injuries of the athlete provide a substantial challenge to the treating physician because of sheer number and diversity of injuries seen in this patient population. Many injuries are initially missed, presenting the challenge of treating a chronic injury in an athlete. The complexity of the hand and wrist can make diagnosis difficult. Thus, it is imperative to have a deep understanding of all types of injuries that can occur in the hand and wrist. With the appropriate knowledge-based orthopedic hand surgeons can usually confirm the diagnosis of athletic injuries of the hand and wrist and provide the appropriate therapy to allow the athlete to return to his or her sport as quickly and safely as possible. The key study point, this is related to the previous portion of the lecture that was given 2 weeks ago, stating that metacarpal and phalangeal fractures are at risk of deformity and function less if not treated appropriately. The hand fingers are at high risk of stiffness if immobilized for extended periods of time. Direction of the finger PIP joint dislocation is important in guiding treatment. Acute pain in the snuff box region in an athlete should be treated aggressively with immobilization for 3 weeks and then reassessment. Focal scaphoid fractures may not be visible on radiographs until 3 weeks post-injury, and for early evaluation, MRI is of benefit. Scaphoid fractures can have poor consequences to the patient. Advancement in wrist arthroscopy have lowered the recurrence rates of dorsal wrist ganglions. Ulnar-sided peripheral tears of the triangular fibrocartilage should be repaired as opposed to debrided. Now we come to a more interesting topic. Now we finished with this lousy topic and we're going into a more interesting topic as far as I'm concerned. I just want to drink a bit of water as the carrier in the second section. By the way, this lecture is divided into 3 sections. One is the distal wrist and its signs and symptoms of pain on the radial and ulnar aspect of the wrist. Second is this chronic overuse elbow disorders. And the third is on nerves of the upper extremity and signs and symptoms of compression at various sites of these nerves. Meaning we'll discuss the radial tunnel syndrome, the posterior anterior osseous syndrome, the cubital tunnel syndrome, etc. Okay. Chronic overuse. elbow tendinopathy is the most common cause of elbow pain. Competitive and recreational athletes, laborers, office workers engage in repetitive upper extremity activities are all susceptible to this painful, sometimes disabling condition. It remains a substantial cause of activity restriction with lost time from sports, recreation, and occupation. Despite increased understanding of the causes and pathoanatomy of elbow tendinopathy, a lack of consensus remains regarding this optimal management. Multiple treatment options have been described, with most patients ultimately responding to non-surgical care over an extended period. Many different surgical procedures have been described for those patients with recalcitrant symptoms despite appropriate non-surgical treatment. Optimal management of elbow tendinopathy requires a thorough understanding of the pathophysiology, the clinical evaluation, available treatment options, and reported outcomes. Now we come to the interesting part. First of all, we'll be starting with medial epicondylitis. This is known to occur in hockey. This patient is being taught of how to play hockey, how to hold the handle, and the stress is on the medial aspect of the elbow joint. Elbow tendinopathy of the flexor pronator origin. This arises from the medial epicondyle and is commonly referred to as medial epicondylitis. Although lateral epicondylitis is diagnosed up to 7 to 10 times more frequently than the medial elbow tendinopathy. And this can also cause a substantial disability to athletes and those individuals with repetitive occupational requirements. Athletes who are particularly susceptible to the development of medial epicondylitis include baseball players, golfers, and those involved in racket sports such as tennis. Medial epicondylitis primarily affects patients in the 4th and 5th decades of life. The primary etiology appears to be repetitive overuse or stress to the flexor pronator muscle origin in the late cocking and early acceleration phases of the overhead throwing motion. High medial tensile forces and lateral compression forces are generally generated at the elbow. The extreme valgus forces are transmitted medially to the ulnar collateral ligament and the flexor pronator muscle group, which acts as an important secondary and dynamic stabilizer of the elbow. The repetitive stress and loading over time can result in tendon degeneration and tendinopathy in throwers. Similarly, overuse injuries are common in golfers, especially those who have poor technique. A recent electromyographic analysis of the amateur and professional golfers demonstrated substantially increased activity in the pronator teres in the trailing arm of the amateur golfers during the forward swing phase, and a trend toward increased activity of pronator teres during acceleration phase compared with the professional golfers. So, in tennis players, EMG analysis have shown substantially increased activity of the pronator teres and the flexor carpi radialis during the acceleration phase of the overhand serve. Repetitive overuse results in microscopic tears of the flexor pronator origin with subsequent tendinous repair and replacement with immature reparative tissue. So, with time, due to the stress and strain on the medial aspect of the elbow joint, leading to degeneration and micro tears in the pronator teres group of tendons, together with the flexor tendons, leading to pain and leading to medial epicondylitis. Histologically, the tissue is characterized by the absence of inflammatory cells. We don't have inflammatory cells, but we see in angiofibroblastic proliferation. It consists of disorganized collagen, numerous fibroblasts, and vascular hyperplasia. This tendon degeneration has been termed angiofibroblastic tendinosis. In medial epicondylitis, the pathologic tendinosis tissue most commonly involves the pronator teres and the flexor carpi radialis. What about the evaluation? Patients with medial elbow tendinopathy tend to report a gradual onset of elbow pain localized to the medial epicondyle and over the flexor pronator muscle mass. Pain is increased with the offending activity such as throwing or playing golf. Physical examination reveals tenderness over the flexor pronator origin, anterior distal to the medial epicondyle. Pain on resisted pronation of the forearm has been found to be the most sensitive physical examination finding. Pain can also be reproduced from resisted wrist flexion. Any strain on the medial aspect of the elbow will produce pain. Grip strength can be decreased as well. With medial elbow pain, one should include a complete evaluation of the integrity of the ulnar collateral ligament and assessment for ulnar neuritis, both of which can coexist with medial epicondylitis. So you have to look at the differential diagnosis, like we did in the wrist, ulnar and radial wrist pain. Now we speak about medial elbow pain leading to medial epicondylitis. It can be also an ulnar collateral ligament injury, can be an ulnar neuritis. You should keep this in mind. Put it as a differential point in your brain. Don't forget it. Ulnar neuritis has been reported in up to 60% of patients, with ultimately requiring surgery for medial epicondylitis. Plain radiographs are typically normal, although calcifications can sometimes be seen adjacent to the medial epicondyle, although primarily a clinical diagnosis, advanced imaging can help evaluate for suspected associated conditions. One study evaluated the MRI findings of 13 patients with a clinical diagnosis of medial epicondylitis. Compared with age-matched control patients, the most specific MRI findings for medial epicondylitis are the presence of intermediate to high T2 weighted signal intensity or high T2 weighted signal intensity within the common flexor tendon and the presence of paratendinous soft tissue edema. Another study found a sensitivity of 95% and specificity of 92% for ultrasonography in the diagnosis of clinical medial epicondylitis. The most common positive ultrasonographic findings in patients with medial epicondylitis were focal hypoechoic regions demonstrating tendinopathy, focal anechoic areas indicating partial common flexor tendon tears, cortical irregularities, and tendon thickening. The use of ultrasonography in the office setting is increasing recently, especially in the treatment of medial and lateral elbow tendinopathy with injections and other procedures. What about the treatment of medial epicondylitis? Although the existing literature is replete with reports of widely varied non-surgical treatment options for lateral epicondylitis, relatively little is dedicated specifically to medial epicondylitis. Non-surgical treatment options include rest, activity modifications, counterforce bracing, physical therapy, oral and topical non-steroidal anti-inflammatory drugs, and injections with corticosteroids, in addition to the more recent use of platelet-rich plasma and autologous blood. In the past, we didn't have the instrumentation to produce platelet-rich plasma. I used to remove blood and then inject it into the local area. And believe me, I've had some good response in quite a number of cases. And it's a cheap way of dealing with the condition. The randomized double-blind study comparing an injection of methylprednisolone with an injection of saline in patients with medial epicondylitis found only short-term benefit in pain relief at 5 weeks for patients in the methylprednisolone group. No differences were found regarding pain relief at 3 months or 1 year after injection. One case series investigated the use of dry needling and injections of autologous blood under ultrasonographic guidance in 20 patients with medial elbow tendinopathy. This technique was used by me at times. At final follow-up of 10 months to 3 months, in 3 patients were considered to have unsuccessful results, and the remaining patients demonstrated substantial decrease in the visual analog scale, the VAS pain scores, and modification of the inertial pain scores. So there was improvement in these patients that we injected blood in. Okay? Although the use of PRP being studied in the treatment of lateral epicondylitis, to date, no reports are available for the treatment of medial elbow tendinopathy. Why is the screen paused? I didn't ask it to be paused. عم تسمعوني? Is the screen moving? يا جماعة.
بروف تفضل.
عم تقشعوا السلايد؟ عم بتغير السلايد لأن عم بتقول لي your screen sharing is paused.
السلايد الآن واقف على final follow up of 10 months.
10 months. Let me see where it is. اوكي بس كيف بدي شيلها هيدي لان عم بتقول لي your screen sharing is paused. ليه؟ I really don't know.
دكتور جون.
ايه
كيفك؟
لك اهلا عم بتقول لي the screen is paused. ما بعرف ليه وجيتني شيء.
ممكن تعمل شير من جديد يا دكتور جون.
برجع بفوت شيرنج.
ايوه احسن.
بالله بتركم. يلا عم تقشعوا هلا؟
ايوه هلا موجود يا دكتور جون.
اوكي.
although the use of PRP.
نعم هذه اوكي great. بس ليك خالد بدي اعرف عم بيسمعوا مبسوطين من اللكشر هلا؟
لا مبسوطين جدا وهي انفولد بكل شيء بالريست والان تمام ما شاء الله.
هيدي شيء مهم كثير صدقني. this lecture I think it's a very important lecture. وبتقشعوا هلا بس I reached the third part of the lectures on the course of the nerves from the brachial plexus to the wrist and what you can have as signs and symptoms of compression. These will help any candidate in board to diagnose condition. Okay. Although the use of PRP has been studied in the treatment of lateral epicondylitis, to date, no reports are available on the treatment of medial tendinopathy. Successful non-surgical treatment has been reported in 35 to 90% of cases. Surgical treatment is reserved for those patients with refractory symptoms, even at least 5 months of non-surgical care. In contrast to the numerous reports of surgical treatment of lateral elbow tendinopathy, few reports regarding surgical management of medial epicondylitis are published. Although percutaneous and open flexor releases have been described, the current consensus for surgical treatment is open. I repeat, open resection of the pathologic tendinosis tissue from the flexor pronata origin. I repeat, you have to resect the pathologic tendinosis tissue from the flexor pronata origin, just as we can do with the lateral epicondylitis which I will be discussing later on. This is the technique of the approach and the surgery and of the detachment of the tendons, the pronata teres, the flexor tendons, and then you remove the degenerative portion of the tendon, and then you resuture it. So you have to see this clinical presentation. The planned incision is marked in the slide in A. It progresses distally from the medial epicondyle. The medial epicondyle, the olecranon, and the position of the ulnar nerve are outlined on the skin. In B, a portion of the flexor pronata origin is detached, as I mentioned recently, from the medial epicondyle and reflected distally. In C, the tendinous tissue is removed from the undersurface of the flexor pronata tendons. The ulnar nerve is identified and either simply decompressed or transposed based on the presence and severity of the preoperative ulnar nerve symptoms. So the tendinosis is resected from the pronata teres group and the flexor group. You remove it, you discard it, but you leave a cuff so as to be able to repair the tendon back again. The flexor pronata mass is securely repaired back to the medial epicondyle after you have done this. So with Shilua, you detach it just like you do with the extensor carpi radialis, brevis, and the lateral epicondyle. You remove it, you remove the tendinosis, then you resuture it back. The success of debridement is substantially influenced by the presence of concurrent ulnar neuritis. Overall, 87% good to excellent results were reported in 30 patients treated with flexor pronata origin debridement at a mean follow-up of 7 years. However, the status of the ulnar nerve correlated with the outcome. Good to excellent results were found in 96% of patients with no or associated mild ulnar neuropathy, compared with only 40% good to excellent results in those patients with moderate to severe ulnar neuropathy. Currently, no studies have evaluated the results of ulnar nerve decompression versus anterior transposition in patients with associated ulnar neuritis. Most case studies detail high rates of pain relief and success with various outcome measures. Overall rate of return to the same level of sport ranges from 69 to 95%. A recent case series of 22 elbows treated with open flexor pronata tendinosis resection detailed 93% improvement in mean VAS scores for pain, 94% for pain at rest, and 33% improvement for pain with heavy activity at a mean follow-up of 36 months. So the treatment is effective. The patient's perception of their arm function, as measured by the disability of the arm, shoulder, and hand DASH scores, substantially improved to the levels of the general health population, with 90% of patients overall satisfied with their outcome. Now, I would just like to mention that there is a technique where a portion of the medial epicondyle is resected, and this relieves the tension on the ulnar nerve. But you have to be very careful in this case so as not to tear or injure the ulnar collateral ligament. Now, they claim it gives us a good result, but I really feel that the best technique that one can use is to detach the pronator teres group and the flexors, remove the tendinosis, then finally repair it and immobilize it for some time, and then the results are quite good. Now, the more common condition is lateral epicondylitis. Lateral elbow tendinopathy, or tennis elbow, is the most common cause of lateral elbow pain in the adult population. Although it can occur in up to 50% of recreational tennis players, lateral elbow tendinopathy frequently affects other athletes and workers whose occupation requires repetitive wrist extension activities. The dominant arm is the most commonly involved, with an equal incidence in men and women in the general population. Acute onset of symptoms can be seen in young athletes, whereas chronic recalcitrant symptoms typically occur in older patients. It primarily affects patients in their fourth or fifth decades of life. The primary etiology for lateral elbow tendinopathy appears to be repetitive overuse or stress to the wrist extensor origin. The extensor carpi radialis brevis is most commonly affected, and there are some authorities who believe that it is the rubbing of the extensor carpi radialis brevis on the capitellum that causes it. Repeated rubbing, although portions of the extensor digitorum communis can also be involved. So if you're asked in examinations, what are the tendons that are involved? Just remember that it is these two common extensor tendons that are involved. Several authors have promoted the most commonly accepted theory of the pathogenesis of lateral epicondylitis. Repetitive overuse results in microscopic tears of the extensor carpi radialis brevis. Attempted repair and failure of healing results in degenerative changes in the tendon, characterized, as we mentioned, for medial epicondylitis, fibroblast proliferation and collagenization, and vascular hyperplasia. There is no sign. There are many who are confused and they say epicondylitis fits its name. It's an inflammation. It's not an inflammation. It is due to fibroblastic proliferation, disorganized collagen formation, and vascular hyperplasia. No inflammatory cells are present. The degenerative or degenerated angiofibroblastic tendinosis tissue is similar histologically to that found in the medial elbow tendinopathy. One study noted increased rates of cellular apoptosis and autophagic cell death in surgical specimens of extensor carpi radialis brevis tendon with associated collagen deterioration and breakdowns. A recent cadaver study demonstrated impingement of the extensor carpi radialis brevis origin on the lateral edge of the capitellum during extension as a potential anatomic contribution to the development of lateral epicondylitis. So the evaluation, patients with lateral elbow tendinopathy report lateral elbow pain that can radiate down the forearm. Occasionally, the patient may recall a specific injury to the area, but the history is typically of a gradual, progressive nature. Symptoms include weakness of grip strength, affecting work activities, sports performance, and sometimes even activities of daily living, difficulty picking up objects, and shaking hands may be noted. On examination, point tenderness is located at just anterior, and distant to the lateral epicondyle. This is very important, this localization, to distinguish it from radial tunnel syndrome, which I will be discussing later on. Pain is reproduced on resisted wrist extension, which can be greater with the elbow extended than with the elbow flexed. The differential diagnosis for lateral elbow pain includes synovial plica, radiocapitellar arthritis, posterolateral rotatory instability, radial tunnel syndrome, osteochondritis dissecans of the capitellum, and cervical radiculopathy. Plain radiographs are typically normal, although calcifications can sometimes be seen adjacent to the lateral epicondyle. Although primarily a clinical diagnosis, advanced imaging can be useful in patients with symptoms refractory to treatment and those with atypical symptoms or presentation. MRI may demonstrate increased T2 weighted signal and extensor tendon thickening. MRI findings have been shown to correlate with surgical and histologic findings. However, one study noted that severity of MRI signal changes consistent with tendon degeneration did not correlate positively with patient symptoms. Ultrasonography has been described as a useful diagnostic tool as an adjunct to treatment of lateral epicondylitis. Fine study reported on 62 elbows with lateral epicondylitis that underwent ultrasonography assessment of the common extensor tendon at diagnosis and after 5 months of physical therapy. Pain and functional disability were assessed using a validated tennis elbow questionnaire. The presence of a large intrasubstance there was found to be predictive of a poor outcome and less likely to respond to non-invasive treatment. So what about the treatment? In 1936, it was proposed that tennis elbow have only one type of treatment. However, the increasing literature of myriad proposed non-surgical treatment options with sometimes conflicting results, different outcomes, measurements, and varied levels of evidence makes direct comparison difficult. A recent systematic review of randomized controlled trials of non-surgical treatment concluded no conclusive evidence exists of one preferred method of non-surgical treatment of lateral epicondylitis. The assessment of all non-surgical treatment options must also consider the favorable natural history of the condition with resolution of approximately 80% of cases within 1 year. If you leave them without treatment, they can heal. So this is the point you should take note of. So the non-surgical treatment options included benign neglect, rest, activity modification, physical therapy, bracing or splinting, oral and topical medications. Now, I want to tell you, there is a medication that we use for heart, nitroglycerin. There is a special ointment which is made up of nitroglycerin. You can rub the area of the tennis elbow. I have tried it. You rub the area, and for some reason or other, most of the pain disappears with time. Irrespective of type of non-surgical care, almost 90% of patients ultimately respond successfully, sometimes after an extended period. For overall improvement has been noted in patients whose employment involves manual labor, who have dominant arm involvement, and who have higher levels of baseline pain. Physical therapy with stretching, pay attention, stretching in conjunction with modalities including iontophoresis, friction, massage, ultrasonography, electrical stimulation can be instituted, although the efficacy of these modalities remains unproved. The addition of eccentric extensor strengthening has been investigated based on prior success with patella and Achilles tendinopathy. A recent systematic review evaluating the utility of eccentric extensor strengthening support its inclusions as part of the multimodal treatment program for improvement or improved outcomes in patients with lateral epicondylitis. Forearm counter force straps and wrist extension splints are two common orthoses prescribed as part of a non-surgical treatment regimen. Although the pathology of the elbow tendinopathy does not support an inflammatory component, both oral and topical non-steroidal anti-inflammatory drugs are commonly prescribed. In a Cochrane review, 15 clinical trials were examined to determine the benefits and disadvantages of both oral and topical non-steroidal anti-inflammatory drugs. Although firm conclusions were not drawn from the available evidence, data suggests that topical non-steroidal anti-inflammatory drugs. نعم
دكتور جون.
اي نعم شو
دكتور جون عم تسمعني؟
ايه عم بسمعك.
السلايد مختفي، مش موجود السلايد بتاع المحاضرة.
عم بوقف السلايد هلا.
اي ما فيش سلايد، السلايد مختفي.
انا رح برجع بفوت ان شير مثل ما عملنا قبل.
ممكن تعيد الشير سكرين مرة.
يلا
اوكي
بس هلا شايف.
السلايد مش موجود يا دكتور، في بلاك.
يلا هلا بينت. بينت.
لا دكتور لا لسه.
لسه فسلاح برجع بيظهر نهائيا.
الآن بين.
هلا بينت؟
اوكي الآن بين الدكتور.
لكن although firm conclusions were not drawn from available evidence that suggests that topical non-steroidal anti-inflammatory drugs are more effective than placebo in providing short-term pain relief in patients with lateral epicondylitis with a small risk of transient skin rash. Now, I want you to take also a point. Then I have tried this and it works. Patients in the glyceryl trinitrate group, there is an ointment, glyceryl trinitrate group. It demonstrated substantially decreased elbow pain, reduced epicondylar tenderness, and improved with extensive strength compared with the placebo group. So I will advise you, orthopedic surgeons who are in practice, get the glyceryl trinitrate group ointment and let the patient rub over the area of pain, and it has given good results. I'm telling you this from trial. I have used it, and it works, believe me. At 6 months, 31% of the treated patients were asymptomatic with activities of daily living versus 60% of those treated with rehabilitation alone. Extracorporeal shockwave therapy has been proposed as an effective treatment option, but evidence remains mixed, with one systematic review finding that most trials showed no benefit over placebo. Multiple injection therapies have been described, including the use of glucocorticoids and PRPs, autologous blood, autologous stenocytes, sodium hyaluronate, botulinum toxin, polydocanal, etc., glycosyl, amino, glycan, polysulfate. All these have been tried. The use of glucocorticoid injections are common in clinical practice, despite the lack of inflammation seen in chronic elbow tendinopathy. Please keep this in mind. There is no inflammation in epicondylitis, even though the name implies it. Randomized studies comparing glucocorticoid injection with naproxen or placebo, or with physiotherapy, or a wait-and-see approach demonstrated substantial improvements in pain and function with glucocorticoid injection compared with other treatment arms at short-term evaluations, meaning from 4 to 6 weeks. Several high-level studies have evaluated the use of PRP injections. In one study, an injection of leukocyte-rich PRP was compared with an injection of corticosteroid using a peppering technique in a randomized controlled trial of 100 patients. The PRP cohort demonstrated substantial improvements in pain and function at 6 months and at 1 year compared with the baseline and the corticosteroid cohort. These results were maintained in a follow-up study at 2 years. PRP-treated patients demonstrated 69% improvement in pain versus 36% improvement in corticosteroid cohort. In a multi-center randomized controlled trial of 230 patients, a leukocyte-rich PRP injection was compared with a control group of needling without PRP. Substantial differences were not noted until final follow-up at 24 weeks, when 84% of PRP group was determined to have successful treatment compared with 68% of the control group. At a 2013 systemic review or systematic review of use of PRP in the treatment of lateral epicondylitis suggested that PRP has been shown to be of benefit over corticosteroid treatment, and a network meta-analysis concluded PRP and autologous blood injections were all substantially more efficacious than placebo. What about the surgical treatment recommended in patients with recalcitrant symptoms even after 6 months or more of non-surgical care? Numerous reports of surgical management have been published with a wide variety of techniques used. The most common currently include is percutaneous extensor tendon release, open tendinosis resection, and arthroscopic resection. Most studies detail high rates of success with limited follow-up. A paucity of well-designed controlled studies support one technique over another. Therefore, the type of procedure used should be based on surgeon comfort and experience. Currently, open treatment includes resection of the extensor carpi radialis brevis, tendinosis, tissue, with or without repair of the extensor tendon origin. You see, the way I do it through a lateral approach, the kosher approach. I expose the common extensor. I make 2 parallel incisions, parallel to each other, at the distance of around 1 centimeter width. This extends to the epicondyle. I resect this portion. I look for any tendinosis. I resect it. Then I suture back the extensor carpi radialis brevis loosely, without tension. Now, in the past, I used to remove 1/3 of the annulus between the neck of the tail, neck of the head of the radius and the ulna, and I used to remove 1/3 of the distance. And believe me, I had very good results. I have many patients returning to tennis, playing squash, and doing many sportish activities. So a good approach is to lengthen the common extensor, which is the extensor carpi radialis brevis, and cleaning the tendinosis and then resuturing it back loosely. But don't forget, I usually roughen the lateral epicondyle, meaning I use an osteotome and I roughen it up before I suture the tendon back. Long-term follow-up study of the inertial open tendinosis action technique reported 84% good to excellent results based on outcome measurements, with 93% of patients available at 10-year follow-up returning to sports. Proponents of arthroscopic resection similarly detail high rate of success with additional benefits of identifying and treating concurrent intra-articular pathology. And this is the technique used. You can see the extensor carpi radialis longest tendon. You can see a partial tear of the sensor in the capsule. And in C, you see finally a resected or released extensor carpi radialis brevis muscle plus debridement of the tendon. This is when it's done arthroscopically. I don't do it after. Elbow tendinopathy is a common cause of pain and disability resulting from repetitive overuse activities. Non-surgical treatment is successful in most cases, with surgical intervention reserved for those patients with continued symptoms after 6 months or more of treatment. Many treatment options are available, but currently no consensus exists regarding optimal management. Additional well-designed comparative studies are needed to better evaluate an ideal treatment algorithm with comparison with the natural history of the condition. So the take-home message, overuse disorders of the elbow are common and can be substantially cause of pain and disability resulting in loss of time from work and sport. Elbow tendinopathy is not an inflammatory condition, but rather tendon degeneration resulting in from continued microtrauma and failed attempts at healing. Many non-surgical treatment options are available. Rest and activity modification are paramount. The current literature provides no definitive recommendation regarding the efficacy of non-surgical interventions. Regardless of treatment type, most symptoms improve over time. Now we come to the third part of the lecture, and this is entrapment neuropathies of the arm and elbow. I wonder, are there any questions so far؟ خالد في شيء مش مفهوم؟ في شيء بيحبوا يسألوا؟ Any questions? No questions? Are you listening? Are you hearing?
الشباب دكتور جون، شباب الدكتور جون بيقول في أي سؤال؟ في الشات مثلا علشان يبدأ الدكتور، وإذا في أي سؤال في الشات ممكن.
I'm not hearing. I'm not.
يلا استمر الدكتور جون، استمر عاد.
What is the question? في شي سؤال خالد؟
لا خلاص دكتور جون يعني استمر
Okay.
عادي.
هلا I'm moving to the interesting part of the lecture. This is a very important portion. Okay, this is a very important sector of this lecture. Entrapment neuropathies of the arm, elbow, and forearm. Entrapment neuropathy is a condition wherein compression or external pressure applies to the nerve and alters its function. Multiple potential etiologies exist, including a space-occupying lesion, inflammatory processes, edema, or compression via anatomic structures. Lesions can present as either acute or chronic condition. If untreated, the sequelae of prolonged compression can result in permanent compromise of function. Let's say if you have an injury of a nerve and you're waiting on it, could it be a neuropraxia? You should not wait for it too long. You should follow it up by Tinner's sign. You should follow it up by doing nerve conduction studies and EMG studies. Because if you wait too long, if it becomes chronic, then you won't have a recovery. The most that we like to wait is 3 months if we're suspecting neuropraxia or axontomesis, but not neurotomesis. The median nerve at the wrist is the most common nerve compression in the upper extremity, but other sites of compression of the median, ulnar, and radial nerves in the arm, elbow, and forearm occur and can be problematic to the orthopedic surgeon and to the athlete. The entrapment of a nerve as a result of any pathologic process can progress to neural injury and dysfunction. Initially, nerves experience edema secondary to compression, although this may be clinically silent or intermittent. Sensory fibers are typically affected first. Pay attention. If you're asked the question, if a nerve is under pressure, which one would be affected first? Is it the sensory or the motor fibers? You should answer the sensory fibers are typically affected first due to the lower threshold of injury because they are less invested in protected myelin sheaths with smaller dimensions. Therefore, the myelin sheath is protective to the nerve. Prolonged compression results in an inflammatory response, microvascular changes, and Schwann cell degeneration. A greater degree, severity of compression can progress to include motor dysfunction and may ultimately result in irreversible changes. What do we mean by a double crush phenomena? It is a condition where the axons distal to the injury site are at increased risk of further injury due to affected axonal transport and myelin or Schwann cell injury that propagates distally. So in other words, it's more or less a further distal injury to the nerve, not only at the site you're suspecting. You should rule out other sites of injury. This is what we mean by double crush phenomena. Patient recovery and relief of symptoms is dependent on release of all sites of compression along the course of the affected nerve. This is relevant to what I was telling you, that when you have a double crush syndrome, areas where the nerve is at compression at different regions, you should release all the sites of compression so as to treat the affected nerve. Patients with entrapment neuropathy may present with motor dysfunction, weakness, sensory dysfunction, numbness, or both, with specific patterns dependent on the nerve and site of compression. Symptoms often follow typical patterns given the anatomic distribution of the affected nerve and the range of intermittent to constant symptoms that may vary in severity. The duration and severity of symptoms may play a role in projecting outcomes following surgery. Examination of an extremity must always begin proximally, not distally, proximally, especially with nerve-related complaints, to evaluate contributing or confounding factors that, such as, for instance, you'll have pain in the hand or the forearm. This can be from the cervical spine. You should not examine the hand and forearm and forget about the cervical spine, or the aforementioned double crush phenomena. Isolated motor neuropathies, such as anterior or posterior interosseous nerve syndrome. These will present with weakness or paralysis in the associated motor groups. Sensory findings follow anatomic distributions presenting as diminished or altered sensation, altered sensitivity, light touch, determined with Sims-Weinstein monofilaments, is an early finding, whereas changes in 2-point discrimination are late findings. So you have to pay attention to this. Light touch examination and 2-point discrimination examination is also a late finding. Entrapment allows injured nerves susceptible to manual irritation of provocation of sensory symptoms identified by the presence of a positive tinel sign or distal paresthesias, sensations which occur when percussing a nerve in an area of irritation. What about imaging? Radiographic imaging has a limited role in evaluation of entrapment neuropathy. In situations such as heterotopic ossification or post-traumatic elbow conditions, osseous anatomic anomalies may exist that result in nerve entrapment. Ultrasound appears promising, but there are limited data regarding its role. It can be used in cubital tunnel syndrome as the ulnar nerve undergoes changes in cross-sectional area with entrapment at the elbow, and nerve subluxation can be visualized. It also helps in the management and diagnosis of carpal tunnel syndrome. Magnetic resonance imaging provides information regarding soft tissue anatomy and can occasionally be valuable in entrapment neuropathy. By using MRI, cysts or tumors such as lipoma can cause pressure on the nerve and be particularly helpful in evaluating radial nerve in the forearm. MRI evaluates nerve integrity following trauma. It provides valuable information in the setting of motor dysfunction because degenerative changes in muscles can indicate the level of injury or degree of involvement. Electrophysiologic testing, further diagnostic information is available via electrophysiologic evaluation. Nerve compression results in demyelination along the length of the nerve, which progresses distally, impairing conduction velocity. More severe entrapment can progress to asynchronous conduction and even conduction block, with resultant weakness and atrophy and eventual paralysis. Electrodiagnostic studies have two components: nerve conduction velocities and electromyograms. Nerve conduction studies can potentially identify sites of slowing, which can help in diagnosing potential double crush injuries. Increased conduction latencies occur due to demyelination. Sensory nerves demonstrate changes earlier in the disease process due to their lower injury threshold and decreased myelin content in comparison to motor nerves. Amplitude of conducted impulses is proportional to cross-sectional area of the functional axons. Finally, increased motor latency and decreased amplitude indicate more advanced compression. EMG describes the muscle response to stimulation, including motor recruitment. EMG on motor changes lag behind the nerve conduction velocity changes in entrapment neuropathy, indicating more advanced disease. Repeat studies provide useful information in monitoring nerve recovery after intervention, which is most useful in the context of motor function with nerves such as the anterior interosseous and posterior interosseous nerve. Early axonal denervation presents with sharp waves and fibrillation potentials. The onset is 1 to 4 weeks after nerve injury. Chronic injuries demonstrate these patterns with diminished amplitude. A regenerating healing nerve will have motor units with polyphasic patterns and nascent low amplitude potentials on EMG. Let me tell you, the Tinel sign is a very important sign in recovery of nerves. I use it on all my clinical cases. These studies are done with the limb in a resting position. Some athletes only have symptoms with provocation, such as ulnar nerve irritation in throwing athletes. Special circumstances, such as communications or connections with other major nerves, such as the anomalous Martin-Gruber connection, may be making it difficult to match the clinical electrical findings. When he asked me, what is the Martin-Gruber connection? It's a connection between the median and ulnar nerves. So if you can have a tear of or laceration of one of the nerves proximal, the patient would still have function from the adjacent nerve. The Martin-Gruber connection is a motor nerve connection between the median and ulnar nerves in the forearm and can result in retained distal function in the distribution of the transected nerve. Temperature of the limb undergoing evaluation can influence the outcomes, specifically EMG amplitude due to corresponding variations in fluid distributions within the muscle. Therefore, these results should be interpreted with clinical context, with presentation. A trial of non-operative treatment is warranted and pursued for 3 to 6 months, after which persistence or worsening of the symptoms warrants surgical intervention. Severe entrapment or symptoms associated with trauma are best treated with early nerve decompression. Treatment. Non-operative management should include activity modification with avoidance of offending position or movement and the use of an orthosis. Anti-inflammatory medications can help with mild or moderate symptoms. Corticosteroid injections have a limited role in many entrapment neuropathies of the upper extremity, other than carpal tunnel syndrome. Failure of non-operative management or persistence or worsening of the symptoms warrants surgical intervention. Post-operative management of patients should be expected to return to full activity with time dependent upon the procedure and sport position. This is typically a much shorter duration than with osseous or ligamentous injuries, which may be up to 6 months. The athletes must demonstrate the ability to safely take the affected limb through the necessary range of motion and with necessary strength and control to return to play. So the complications: untreated entrapment neuropathy can eventually progress to chronic degeneration and associated permanent nerve dysfunction and muscle atrophy. The risks include wound complications, iatrogenic nerve injuries, inadequate or incomplete surgical decompression, and recurrence of symptoms. A rare but serious complication is the development of the complex regional pain syndrome that we all hate, associated with chronic pain, early vasomotor changes, stiffness and loss of function. It may be associated with chronic nerve entrapment, which can occur with nerve compressions, specific nerve injuries, or trauma in the extremity. So now we come to the interesting part. Each nerve and what the compression can present with. The median nerve. As a medical student and as a resident in Canada at the universities, I was taught how to follow a specific diagram in each of the 3 nerves of the upper extremity. We start first of all by the median nerve. The median nerve is positioned along the anterior aspect of the arm. Initially, it is lateral to the brachial artery, although it crosses over to lie medially upon reaching the antecubital fossa. Approximately 1% of the population has an anomalous supracondylar process. Pay attention, supracondylar humerus process. You can see it in the slide below. The red arrow is pointing to it. This can give rise to a fibrous band that extends from it down to the epicondyle, the medial epicondyle. Between it and the medial epicondyle lies a ligament. It's called the ligament of Stradus. The median nerve can pass underneath it, and at that level, you can have compression of the nerve, the median nerve. The median nerve travels beneath this structure when present and crosses the antecubital fossa, where it is bordered by the brachial artery, which lies lateral, the brachialis posterior, the pronata teres medial, and the lacertus fibrosus, or the bicipital aponeurosis, anterior. The brachial artery lateral, the brachialis posterior, the pronata teres medial, the left surface fibrosis or the bicipital aponeurosis anterior. The nerve then enters the anterior compartment of the forearm between the heads of the pronator teres. It travels distally.
دكتور جون
ايه
دكتور جون الصورة واقفة على واحد من السلايدات.
اياها قولوا لي اي سلايد.
سلايد اللي هو early axonal denervation presents with sharp waves.
With what?
With sharp waves and fibrillation potentials.
عمى ليه ما قالوا لي؟ وين اي؟
لا هلا يعني لاحظنا لانه ثبتت على هذا السلايد.
complications مرقتوا فيها؟
اي الان بتتكلم على الدينيرفيشن والفيبريليشن للشوك ويفز. ايوه
هيدي؟ اوكي
ايوه
يلا بس بدي اعرف اذا ماشي. هلا ماشي؟ if I change would it change؟ ماشي؟
كملها يعني عديها علشان نشوف هل بيمشي ولا لا.
لا بدي اعرف اذا السلايد ماشي. هي عم غير ماشي؟
لا ما بيتغير، ما عم يتغير.
طيب خليني ارجع فوت له.
ايوه
هلا واضحة؟ واضحة؟
هاي دكتور على السلايد بس السلايد الايرلي.
Is it early axonal denervation presents with sharp waves and fibrillation?
اي واضحة. اوكي دكتور.
Okay. Early axonal denervation presents with sharp waves and fibrillation potentials. Onset 1 to 4 weeks after the nerve injury. Chronic injuries demonstrate these patterns, but with diminished amplitude. A regenerating, healing nerve will have motor units with polyphasic patterns and nascent low amplitude potentials on EMG. These studies are done with the limb in the resting position. Some athletes only have symptoms with provocation, such as the ulnar nerve irritation in throwing athletes, because the ulnar nerve is present within the cubital tunnel and it's undergoing stretching as the individual is throwing a ball overhead or a rod, as we saw yesterday in the Olympics. Special circumstances such as communications or connections with other major nerves, such as the anomalous Martin Gruber. Martin Gruber is a connection between the median and ulnar in the forearm. And for this reason, if one has a laceration of one of the nerves proximal, but yet he will have a fully functioning wrist or hand due to the nerve supply being supplied by the other nerve which is connecting to it. The Martin Gruber connection is a major nerve connection and between the median and ulnar nerves, and can result in the retained distal function in the distribution of the transected nerve. The temperature of the limb undergoing evaluation can influence the outcomes, specifically of the EMG amplitude, due to corresponding variations in fluid distribution within the muscle. Therefore, these results should be interpreted within clinical context. With early presentation, a trial of non-operative treatment is warranted and typically pursued for 3 to 6 months, after which persistence or worsening of symptoms warrants surgical intervention. Severe entrapment or symptoms associated with trauma are best treated with early nerve decompression. Non-operative management should include activity modification with avoidance of offending position or movement and use of an orthosis. Anti-inflammatory medications can help with mild or moderate symptoms. Corticosteroids have a limited role in entrapment neuropathies of the upper extremity other than carpal tunnel syndrome. Failure of non-operative management or persistence of worsening of symptoms warrants surgical intervention. Post-operative management, patients should be expected to return to full activity with timing dependent upon the procedure and support position. This is typically a much shorter duration than with osseous or ligamentous injuries, which may be up to 6 months. The athletes must demonstrate the ability to safely take the affected limb through the necessary range of motion and with the necessary strength and control to return to play. The complications we mentioned about wound complications, iatrogenic nerve injury, inadequate complete surgical decompression and recurrence of symptoms. These are complications of doing surgery. There is one complication that we don't like to have, which is the complex regional pain syndrome. This is associated with chronic pain and early vasomotor changes, stiffness and loss of function. It may be associated with chronic nerve entrapment, which can occur with nerve compressions, specific nerve injuries, or trauma in the extremity. Now we come to the median nerve. We were speaking about the supracondylar humerus process over here, and we spoke about the ligament of Stradus, which extends from the process, tip of the process, to the medial epicondyle. And the median nerve, when it passes medially, it passes underneath the ligament of Stradus, and it can be compressed at this level. The median nerve travels beneath the structure when present and crosses the antecubital fossa. The brachial artery lies lateral, the brachialis lies posterior, the pronator teres is medial, the lacerta fibrosus or bicipital aponeurosis is anterior. The nerve then enters the anterior compartment of the forearm between both heads of the pronator teres. It travels distally between the flexor digitorum superficialis and the flexor digitorum profundus. It gives the anterior interosseous nerve in the proximal forearm. The median nerve becomes more superficial, running between the flexor digitorum sublimis and pollicis longus. It gives off the palmar cutaneous nerve and then enters the carpal tunnel at the wrist. It innervates the flexor digitorum sublimis, flexor carpi radialis, and palmaris longus muscle in the forearm. Now, I believe in this diagram. This diagram was given to us. We had it at the university, even as medical students. But I'll tell you, the median nerve originates from the medial and lateral cords. The main origin is from C8 and T1, but it can receive branches from C7, which is coming from the lateral cord. At first, it travels down the arm. It is lateral to the brachial artery, but in the middle aspect of the arm, it passes from lateral to medial. Okay, from lateral to medial. Now, over here, it is at this level that it passes if the process is present, as it occurs in 1% of patients. It passes deep to the ligament of Thrasis and then comes to the antecubital fossa. And there it lies. It passes through the pronata teres, and it lies on the brachialis posteriorly. The brachial artery is lateral. The pronata teres is medial. The bicipital aponeurosis or lacertus fibrosis is anterior. Now, the median nerve, as it goes into the forearm, goes between the profunda artery, profundus tendon, and the sublimis. But in the mid forearm, it goes between the pollicis longus and the flexor carpi ulnaris. So the median nerve then gives a nerve, just a cutaneous, palmar-cutaneous branch to the skin in the palm just before it enters the transverse retinaculum or the flexor retinaculum. Once it passes through the retinaculum, it gives a recurrent branch to the sena muscle. Now, it is here where you get the compartment syndrome, where you get pressure on the median nerve. Okay, so you get the nerve when it's present within the canal, it's under pressure. Mind you, with it are tendons. You can have, in this region, you can have ganglions, you can have lipomas, you can have all sorts of things that can increase the pressure, or you can have conditions which are systemic, like rheumatoid arthritis, gout. All these can increase the pressure within the compartment, within this tunnel, okay? Thus, all would lead to the carpal tunnel syndrome. And there is a condition where the lesion, the nerve becomes hypertrophy, which is called the Salters-Dejerine syndrome. And this will itself will increase pressure within this tunnel. Now, if you have a carpal tunnel syndrome, and if you recall, we spoke about Gien's canal syndrome. If the patient has signs and symptoms of both, you can release the carpal tunnel, and the symptoms will be relieved from both. So you have to know, I repeat, it arises from two cords. The main cord is the medial cord. The lateral cord, you have C7 branch that supplies it. At first, it's lateral to the brachial artery. Then it moves medial and passes medially. If there is a supracondylar process, Then there's a ligament of Stratus that passes in between the process and the medial epicondyle, and it can be under pressure at that level. As it reaches the elbow, it passes through a known anatomic approach that we have spoken about, the brachialis, the brachial artery, the pronator teres, biceps aponeurosis. Then it passes in between both heads of the pronator. It gives a branch, the anterior interosseous nerve. The anterior interosseous nerve passes deep to the sublimis arc and then supplies a portion of the muscles on the palmar aspect, while the median nerve will supply another portion. So this is about the median nerves. You can have compression at various sites at the pronator teres zone, or you can have it at the supracondylar process. You can have it in the region of the sublimis, where a branch is under compression, which is the anterior interosseous nerve. So the anterior interosseous nerve may divide from the median nerve at as proximal as the two heads of the pronator teres, typically in the radial direction. It passes through the flexor digitorum sublimis arch along with the median nerve and progresses distally over the interosseous membrane between the flexor digitorum profundus and flexor pollicis longus. The anterior interosseous nerve terminates at the pronator quadratus muscle after innervating the flexor pollicis longus variable portions of the radial flexor digitorum profundus. As you know, a portion is supplied by the median nerve, and a portion, two heads are supplied by the of the profundus by the median nerve, and the other two are supplied by the ulnar nerve. And the pronator quadratus is supplied by the anterior interosseous nerve. Of note, approximately 22% of the population can present with a connection between the anterior interosseous or median nerve and the ulnar nerve, and this is known as the Martin-Gruber connection. A potential space occupying anomaly is Gansen muscle, and an accessory head of the flexor pollicis longus. So it's the Gansen muscle is a portion of the flexor pollicis longus muscle, which can be present in up to 68% of patients, and this can cause compression. Median nerve compression in the arm and forearm is typically associated with high stress repetitive flexion through the elbow and repetitive forceful pronation. Sports that rely on these motions include archery, baseball, and automobile racing. Pronator teres syndrome is what is important is that you have to notice the difference between it and the carpal tunnel syndrome. It is primarily attributed to the median nerve compression between the two heads of the pronator teres in the forearm. Other sites of entrapment include the proximal arch of the flexor digitorum sublimis, because we mentioned that either the anterior interosseous or both, the median nerve and both, pass deep to this arch, and this can be a site of compression. If the process is present, it can also be under pressure by this ligament of Stratus, or it can be through pressure by the lacertus fibrosus in the antebrachial fossa. So, external compression include tumors, anomalous Ganser muscles. Pronator syndrome has also been described with the presence of persistent median artery. The most common sites of median nerve compression are deep head of the pronator teres the flexor digitorum sublimis arch, lacertus fibrosus. And there are surgeons who feel this is really entrapment at the lacertus fibrosus, and isolated decompression at this level will resolve symptoms. Pronator teres syndrome presents primarily with complaints of pain in the forearm, typically in the proximal anterior region, with minimal weakness or sensory deficits. Notable differentiation, this is a very important, that's why I put it in red. A notable differentiating factor from carpal tunnel syndrome is the absence of nocturnal symptoms. In pronator teres, it doesn't bother them at night. In carpal tunnel, it does. If sensory deficits are present, they can present as numbness or paresthesia and the sena eminence in the distribution of the palmar-cutaneous branch of the median nerve, as well as the volar aspect of the thumb, index, middle and radial aspect of the ring finger, following typical median nerve innervation. I have to go very quickly. As with entrapment neuropathies, provocative maneuvers can help determine a site of compression. Reproducible pain with resisted forearm pronation. Typical. Pronator teres, we said the median nerve is passing in between both heads of the pronator teres. So when you force your forearm into pronation against resistance, this will kink the tendon and the nerve in between, and as a result, they will have symptoms. Keep this in mind. This is a known fact. This shows you of how it's passing deep to the flexor sublimis tendon. We mentioned that the anterior interosseous nerve is given as a branch from the median nerve proximally in the forearm, and both will pass underneath the arch of the sublimis at this level, and this will lead to compression. So you have to pay attention to this, okay? And as a result, we know that the median nerve supplies the lateral 3.5 volar aspects of the fingers, while the ulna supplies the median 1.5 finger sensation. So you have to pay attention to this. I'm going very quickly on this. Now, this shows you the median nerve can be pressed or compressed underneath the lacertus fibrosus or bicipital epineurosis over here. And we have to know that it lies on the brachialis muscle posteriorly. The artery is always lateral, and the pronator teres medial. So keep these all in your mind. So you have to pay attention. Look at this, shows you the process. You see the ligament of Stradus. The median nerve will pass underneath this, and it can be under pressure, leading to a neuropathy. So these are important points. What about the Gainer test? Involves direct compression on the pronator teres. You see the thumb where it is. The pronator teres is over here. So this will give pain. They will have a positive test, which indicates pronator teres compression, and is defined as a provocative symptoms only in the affected limb. Decision-making principles, vague anterior forearm pain is the primary and most reliable reproducible symptoms, whereas history and exam maneuvers are not as specific as in other entrapment neuropathies. Electrodiagnostic studies are often normal. So you have to depend on your clinical ability. Apply pressure on the pronator teres. Ask the patient to pronate the forearm against resistance with pressure on the pronator teres. This is a clinical provocative test that will tell you whether the patient has a pronator teres syndrome. Okay, and imaging ultrasound may be warranted with clinical concern for a space-occupying lesion, such as a cyst, tumor, or evaluate anomalous anatomy. Don't forget that it's not only at sites where the nerve passes and there is pressure that gives you the symptom. You can think of a mass, you can think of an inflammatory process all around the nerve that causes scar tissue, and it will give you signs and symptoms of pressure. So keep this as an important point. Now, initial management should be non-operative, including activity modification to avoid the offending action. Immobilization and anti-inflammatory medications can result in symptom resolution in 50 to 70% of the cases. Treatment options, traditional surgical management requires exposure of the antecubital fossa to address all potential sites of compression of the median nerve. The skin incision typically begins 5 centimeters proximal to the elbow and extends distally to the mid-forearm. Incisions can either follow a lazy S pattern with or without offset, linear incision or transverse incisions. Longitudinal incisions result in more noticeable scarring. Endoscopic assisted decompression has also been described. Now, the lecture is nearly over, but I want to tell you about the other conditions. The most common approach is a lazy S incision that progresses from mid-arm along the medial aspect of the biceps, curving toward the supracondylar region medially and continuing distally over the flexor pronator mass to the mid-forearm. Dissection should preserve the cutaneous nerve branches. Supracondylar exposure should be performed. Release of the ligament of Stradus, if present. The median nerve is identified, traced, identify the potential sites of compression, which we said the pronator teres, we should resect. The sublimis, which I said, the carpal tunnel is also a site. So, or any tumor or masses or any compression resulting from these. So you have to pay attention to this. And now we spoke about the cubital tunnel, which is very important. We spoke about Dean's tunnel. Cubital tunnel is a place where the ulnar nerve passes. It is under pressure by Osborne's ligament, and it passes in between both heads of the flexor carpi ulnaris. So you have to pay attention to this. And the cubital tunnel syndrome is caused by entrapment of the ulnar nerve at the elbow, most commonly under Osborne's ligament at the cubital tunnel. And this is Osborne's ligament. And you have the cubital tunnel, the nerve is underneath it, and then could be compressed. Other common sites of entrapment is at the arcade of Stradus, together with the median nerve, but to a lesser extent, it could be compressed at the arcade of Stradus, the ligament of Stradus, the medial epicondyle, and the arcuate ligament or flexor carpi ulnaris aponeurosis. Now, you can have lipomas or mass lesions, anomalous anatomy such as unconeus epitrochlearis, Compression also occurs under the flexor carpi ulnaris, which we mentioned, because of muscular hypertrophy in athletes, and this would result in direct pressure on the nerve. And these symptoms of ulnar nerve compression at the elbow are commonly seen in baseball players for reasons of repetitive throwing mechanics as previously described. So also it can occur in bicycle, weightlifting, crossing the country skiing, wrestling, and martial arts. Now, as we mentioned, there's a diagram for the median nerve. This is the diagram for the ulnar nerve. Now, if you see from the brachial plexus, the ulnar nerve runs medial to the artery and continues along the forearm, passing beneath or behind the epicondyle in the cubital tunnel. It gives a trochlear branch to the joint. Then it passes between both heads of the flexor carpi ulnaris, descends in the forearm between the flexor carpi ulnaris and the flexor digitorum profundus, and then it arrives at the Guyon's canal between the pisiform and the hamate. It lies medial to the artery, okay, and there it divides into two branches to supply sensation and motor function to the intrinsic muscles of the hand. So know this. You can have pressure in all these areas. In Guyon's canal, you can have it between the two heads of the flexor carpi ulnaris, behind the medial epicondyle and the cubital tunnel by means of Osborne ligament, and you have to know all these points about the passage of the nerve. So what I would suggest, take this diagram. This diagram is very helpful. It is very helpful to follow and learn the anatomy of the ulnar median nerve. The early compression is sensory nature with paresthesia and the small and ulnar half of the ring fingers. These symptoms are often nocturnal due to elbow flexion. When you flex the elbow, it's under tension while sleeping. And chronic or severe entrapment results in muscle weakness in the innervated groups, although often flexor carpi ulnaris and digitorum profundus are spared due to topographic distribution of motor innervation of the ulnar nerve. In athletes, cubital tunnel may primarily present with medial elbow pain aggravated by throwing or with elbow flexion. The differential diagnosis includes a valgus extension overload syndrome, medial epicondylitis that we discussed previously, a flexor pronator muscle strain, and ulnar collateral ligament injury. Reproducible numbness in the ring and small fingers with the elbow flexion through a throwing motion leads to a high index of suspicion for cubital tunnel syndrome. Flexing the elbow and extending the wrist for 1 minute has been demonstrated to be highly accurate for the diagnosis of cubital tunnel syndrome. A positive Tinel sign can often be elicited. Evidence with many clinical signs. You have the Wartenberg sign. This is a sign where when you extend the fingers, you see that the small finger goes into abduction due to the third palmar interosseous muscle weakness. Also, you have to know what Froment sign is. Every resident should know what Froment sign. We ask it quite often. it's secondary to paralysis of the adductor pollicis of the thumb, which is supplied by the ulnar nerve, while the majority of all muscles to the thumb are supplied by the median nerve. And this is showing you of how one would get a Froment sign. He won't be able to maintain his thumb straight. Why? Because the adductor pollicis is not functioning normal. Okay? Use of the flexor pollicis longus due to weakness. Abductor, no, that wouldn't be. So you have to pay attention. Froment sign is pinched. They use the flexor pollicis longus legs, but the adductor pollicis is weak. Okay, this is weakness of the adductor pollicis and the late stage deformity. This is the thing at the Wartenberg sign. The small finger goes into adduction. Muscle weakness is most noticed by the athletes as a decrease in the grip strength, loss of sensation to the dorsum of the small finger and ring fingers is of specific importance because it denotes compression of the ulnar nerve proximal to take out the dorsal sensory branch. So this is enough for the ulnar nerve passage. I think you have to know what studies one should do. And I will go now directly, as to save time, into the posterior interosseous and radial nerve. Okay. A question that many ask me: if you want to decompress the nerve, would you decompress it and leave it in its space? I have done this, and I have transposed the nerve subcutaneously to the front of the cubital fossa, and I found that transposing it is far better. But you have to pay attention that as you're transposing it, you won't promote kinking in the nerve as it passes between both heads of the flexor carpi ulnaris. Be very careful about this. This is for the ulnar nerve. Now, I spoke about medial epicondylectomy for ulnar nerves before in patients who have a medial epicondylitis. But if they have signs and symptoms of nerve problems, the ulnar nerve, you can do it, but you should not overdo it. Remove too much of the epicondyle so as to create an instability of the elbow. You should maintain the ulnar collateral ligament if you do this. I'm sorry I have to go through this because I have so many things to give you, but it's short. Now, I want to just previously mention about the radial nerve. We know about the radial nerve that lies the triceps tendon. It arises from the posterior cord, and we know that it passes through a spiral groove on the humerus. Then it penetrates the lateral intermuscular septum at around 10 centimeters above the elbow joint. And then it divides into two branches, the sensory and the deep. The deep passes through the supinator, through the tunnel. The supinator, you have the radial tunnel over there. It can be under pressure at that level. And then it becomes the posterior interosseous nerve. It can be under pressure throughout this tunnel. And then as it goes distally, it becomes motor branches given and passes medial to the flexor carpi radialis, medial to the brachioradialis and lateral to the flexor carpi radialis. This is the sensory branch. The motor branch is from posterior. It supplies all the extensor tendons to the wrist and hand. And one should distinguish between a radial tunnel syndrome and a tennis elbow is from the site of tenderness on pressure point application. One is more distal to the other, and well, this is on the whole of what I would like to mention. But look at this is, let us see this. This shows you of how the radial nerve arises as a posterior cord. It is lateral to the brachial artery. Over here, it's piercing the intermuscular septum. Over here, it comes to lie over here, go underneath the brachioradialis. It gives a branch into two branches, a sensory branch and the posterior. The sensory is over here. The posterior passes through the supinator and through the radial tunnel, and therefore you can have signs and symptoms at this level. So enough for this. You have to go ahead and, by the way, I just want to mention, it is in the supinator that you have a tunnel, a radial tunnel, and the arcade is known as the arcade of Frauss. So keep this in mind. And that's it. So if there's any questions, please ask me. We know that one of the problems of the radial nerve is we get a fracture of the junction of the middle and distal third of the humerus with the spike, which is called the Holstein spike. And we believe that the radial nerve can be damaged over here. It won't be cut. It will be stretched due to this tension that occurs on the lateral intermuscular septum as the nerve is passing. And as a result, this can lead to a drop to wrist, but with time, they tend to improve. Okay, so these are points I would like to mention. This is just to mention this. This is the radial tunnel. This is the motor branch passing in this tunnel. This is the arcade of Frauss. Okay, the Frauss. This is the radial tunnel and the radial nerve of how it's passing. The superficial branch going in between the brachioradialis and the flexor carpi radialis. Then over here, it's passing posterior to supply all the muscles on the extensor aspect of the wrist. So please keep this in mind. So this is the arcade of Frauss. And look at this point, I got this diagram. I was very happy to have it. It shows you the tenderness of the tennis elbow versus a radial tunnel tenderness. It's more distal. Okay, so you have to include all these in the differential diagnosis, what I told you. And that's it. I think these, you have mainly the clinical findings. The radiologic appearance should not be involved so much. Look at it, showing over here of how you have a sensory branch, you have the motor branch passing through the supinator muscles, through the radial tunnel, and it becomes over here the posterior interosseous nerve, which supplies all the muscles on the extensor. This tells you more about it, of how the nerve is penetrating or passing through a tunnel in the supinator to supply sensations on the dorsal aspect of the hand and motor branches. Okay, so keep this in mind, please. Let me see. This is an approach for the median, for the posterior interosseous nerve, and if we want to remove. This is posterior interosseous nerve compression, where you have pressure as it's passing through the supinator muscle. This shows you it further, and you have the arcade of Frauss, which is over here, the radial tunnel, and further over here. I've done so many purely motor branch of the radial nerve. It passes through the supinator muscles, compression at the arcade of Frauss, and this occurs in racket sports, bowlers, and throwers, and golfers, swimmers, repetitive supination and pronation. So pay attention to this, okay? And these are the muscles supplied by the posterior interosseous nerve or by the motor branch. You have the extensor digitorum communis, extensor carpi ulnaris, the extensor indicis proprius, extensor digitorum minimus, abductor pollicis longus, extensor these muscles that are supplied by each of them, the nerves. Okay, so please pay attention. And these are multiple techniques we use to investigate and to perform surgery. And I tell you, thank you. This was a very long lecture because it included a new lecture together with the termination of a previous lecture. I hope I didn't bore you. I hope I did not bore you.
بالعكس يا
Okay?
دكتور، احنا مستمتعين ولا الشباب متابعين، والدكتور خالد برضه موجود، متابعين كامل.
Thank you so much for listening and bothering to listen to me.
بالعكس يا دكتور، احنا اللي نشكرك اللي بتدي المجهود هذا الكبير للشباب.
Thank you. وشغلة تانية، أنا بعد جمعتين ما هيك رح نرجع لبعد جمعتين. فهي؟
إن شاء الله دكتور.
بعد جمعتين I'll give you another lecture. I would let you know beforehand what the topic is.
اوكي دكتور خالد، معك دكتور.
يلا.
دكتور جون.
يلا thank you.
بيكمل.
إيه؟
بتكمل.
كيفك يا خالد؟ بعدنا طيبين.
أيوة
يا
معاك.
خالد بعدنا عايشين.
الله يعطيك العافية إن شاء الله، وإن شاء الله تنفك يعني تنفرج بإذن الله الدنيا.
أقولك رح تنحل؟
إن شاء الله. أيوة.
الله يسمع منك، الله يسمع منك.
إن شاء الله ما تضيق إلا وتفرج يعني إن شاء الله.
يلا أوكي يلا thank you and see you in 2 weeks.
إن شاء الله إن شاء الله. خلاص. ما